Ivan, would you like us to give people a minute or two to log in?
Yes, I think I've got 6:59 here.
Yeah.
Maybe we'll wait. And if I could ask everybody to mute their microphones, we were going to do that, but if you could all just mute, that would be great. We won't have any stray audio. And again, if you want to speak tonight, I don't know, Alika, are you okay with people asking questions through the presentation, or would you prefer to wait till the end? Because we do have some time set for like a Q&A and discussion.
Yeah, I'll leave it open to the audience. If
Okay.
they have any questions, they can throw it in chat, and
Right.
yeah, I'm
So
happy to pause at different times.
perfect. So just raise your hands electronically. If that doesn't work, then flip open your screen and wave, and Coley or I will identify you, and then you can introduce yourself and ask your question. Yeah, we'll keep it simple. Oh boy, wow, it's a good turnout. We'll give it one more minute, Barb, and then we can start, I think, because it looks to me like people were very conscientious about coming in before 7, so
Well, they didn't come to hear me, so I'll do my little spiel and then back away
okay,
for the main event.
perfect. Over to you, Barb.
Thank you. Good evening, everyone. It is my pleasure to welcome each and every one of you for joining us for the presentation tonight by Dr. Alika Lafontaine, entitled Hostility in Healthcare, Racism, Working Environments, and Cultural Change. My name is Barb Konstantinovich, and for those of you who don't know, I'm a former president of the SMA and the chair of the SMA's Equity, Diversity, and Inclusion Committee, and it's my privilege to host this meeting. Since we are participating in this meeting virtually from all parts of our province, I want to begin by acknowledging that we are gathered on Treaty 2, 4, 5, 6, 7, 8, and 10 territories and the homeland of the Métis. As such, we pay our respects to the traditional caretakers of this land. We affirm our commitment to reconciliation, our shared stewardship of the land, and our relationship with one another. Racism is an issue of our profession and within the healthcare system generally. The SMA's EDI committee was formed by the SMA's board of directors during my term as president in 2020-2021, and I have been pleased to serve on this committee, and tonight's session is part of that committee's mission to generate greater awareness of EDI issues. Early feedback to the committee made it clear that education was key, and tonight's presentation and discussion will help physicians in this province develop a fuller understanding of the issues of racism in the medical profession and the wider healthcare system. I'm very honored to welcome Dr. Alika Lafontaine, the president-elect of the Canadian Medical Association. He will share his insights on systemic racism in Canada's healthcare system, and we are grateful to have you, Dr. Lafontaine, speak to the physicians of Saskatchewan. The SMA envisions this as a first in a series of educational opportunities, which we hope will help the organization build greater awareness about the issues of racism, diversity, and inclusion in the medical profession. Dr. Lafontaine is no stranger to Saskatchewan and to the issues we confront as physicians. He was born and raised in southern Saskatchewan with mixed Indigenous ancestry of Métis, Anishinaabe, Cree, and Pacific Islander. He is an award-winning physician, a social innovator, and the first Indigenous doctor listed in the Medical Post's 50 Most Powerful Doctors. Dr. Lafontaine has served in medical leadership positions for almost 2 decades, and in 2022, he becomes our first Indigenous physician president of the Canadian Medical Association. I want to put you in Saskatchewan, so sorry if I made a mistake there. He is a respected authority on health systems, change management, social innovation, anti-racism, and reflective practice. The Saskatchewan Medical Association appreciates funding from Scotiabank, MD Financial, and the Canadian Medical Association as part of their physician wellness and initiative to address the urgent, ongoing health and wellness needs of our medical community. The Physician Wellness Initiative supports various SMA's initiative. As mentioned earlier, we'll hear from Dr. Lafontaine, and I will moderate questions and answers. It is now my pleasure to introduce Dr. Lafontaine. Thank you for the presentation.
And thank you so much for that really, really kind introduction. I see many faces or names, I guess, that I recognize. My time in Saskatchewan growing up and also in training still bring back really, really fond memories. I still think even after 12 years here in Alberta that, sunsets in Saskatchewan can't be beat. And thanks for taking time out of your evening to participate in the discussion today. It will be at times a bit of a heavy discussion. And so I want to encourage you to reach out to the SMA and their physician support program if you feel like you need some extra attention and care. These are hard things sometimes to discuss, and I'll try and use kind of a mix of kind of light and heavy as we go through this. But I've always thought that whenever talking about, the core issues that create stresses for us in the healthcare system, it's really important just to make sure that we keep these conversations authentic and, we just call things as they are. I also feel that talking about equity, diversity, inclusion, racism, etc., is something that has been built into a lot of our discussions. And so this presentation really isn't a kind of racism 101, but more talking about ways that we can conceptualize and frame these discussions. That way we can get to that next place of really talking to each other authentically and hopefully working through some of the issues that stand as barriers to actually solving these problems. So I've started to look at kind of society in a way that helps to frame health in kind of its position. There's this soil that we all kind of exist in. Part of it is the social fabric, where we have our shared philosophies, languages, diversity of opinion, the norms of how we interact with each other, our community cohesion. Is kind of part of the soil. And then with that, we kind of have these economic systems where we choose how we value and what we value. And I think sometimes when we talk about economics, we strictly talk about things like stock markets and other things. But I think you've seen a shift in the values that we've shared as a society where, things like equity, diversity, inclusion, addressing oppression, working through power structures, making sure that our systems actually satisfy the needs of our most vulnerable have become very important, especially in the last 10 years. And so from this soil, there spring up a bunch of trees, and these trees represent the different parts of society that help to ensure that we live in, a comfortable and sustainable way that really lets us grow and learn and become a part of society and, give back to that soil that helps to grow and sustain, these different trees that represent, health, education, our social support systems. There's lots of trees out there and lots of labels that we can give to kind of what grows out of the soil of a well-functioning society. Now, nowadays, it feels like the soil has really turned to sand in a lot of places. And I think particularly within healthcare, I imagine all of you are going through the same things that I'm going through here in Alberta. And I hear these stories from across the country where, it feels like the tree leaves have really fallen and, things are pretty sparse and the sun is kind of beating down on us. And at times it can feel like, things are a bit on fire. When I discuss things in private physician groups and somebody inevitably asks the question, how are you guys doing? The most common meme I actually see is that of a dumpster on fire floating down a river, And I imagine that that's sometimes how it feels going to work. And it's in this context that we see a lot of things happening. So this is a word map that I pulled together. I took the 10 most recent statements from our national medical advocacy organizations, not just the CMA, but also the Canadian Nurse Association, national groups like Doctors for Medicare, equity seeking groups like Equity in Medicine, the Canadian Women's um, representative organizations that advocate for, gender equity. And these are the words that kind of bounce out. And I imagine that a lot of these words are things that you see day to day. You know, the pandemic has really brought us to a place where we're very, very stressed out, and in a lot of places we're going through crises. This is from the last week, just news article, uh, news article titles, and you can see that in Saskatchewan and elsewhere across the country, people are struggling to find primary care. Surgery wait lists are expanding. Care in general is suffering, and people are really struggling to find different doctors to solve different problems that they have. And things are happening over the last year that you never really thought about when you were in training or in practice. People being confronted with life-threatening situations, people being under attack, the quick shift that went from doctors and other healthcare professionals being heroes to now being part of systems that oppress. And all of that kind of weighs, I think, on the minds of the persons who are on this call, but also our colleagues. And so it's in this environment that we're now talking about equity, diversity, inclusion, anti-racism, um, the things that need to change in the context of crises that are ongoing and happening within the system. Um, and I think it is important to note that our healthcare systems do seem in perpetual crisis, and we're starting to do things that we have never normalized before. We always knew that whenever there was hospital overcapacity, that we just placed patients wherever they could go. But the truth is, we never actually said that out loud. We didn't expect people to accept that as a status quo. And making changes in systems like this in the middle of crisis is often very challenging. And I think that that's part of what I'm hoping we can talk about today and kind of unpack in the context of racism, but then in a lot of other ways that the system needs to change moving forward. So I'm gonna just do a little exercise with people on the call today. I'm hoping that you can make use of your chat function, which I'll open up for myself. Um, I'm going to do an exercise where I'm just going to share with you a paragraph. Some of you might have seen this before if you've seen some of my other presentations. And I'm just going to give you the task of counting the F's within the paragraph. And don't type anything to the chat yet. Don't speak out loud yet. I'll kind of ask you how many F's you see in a little bit, but I'll put up the paragraph. I'll give you 3 seconds, and then we'll see how many F's you actually count. So I'm going to put the paragraph up here, and I'm going to give you 3 seconds. So I'm just going to call it 1, 2, and 3. And I'm going to ask people in the chat if you saw 3 F's just to type the letter 3. So just those who saw 3 F's, just go into the chat and type the letter 3. Okay, perfect. Okay, good. Yeah, keep on tapping those 3s if you saw 3. Okay, excellent. If you saw 3, continue tapping, but anyone see 4 F's? Type in the letter 4. Okay, we see a good mix. We see a number 2. And if anyone saw more than 4, just to type in that number there as well. Yeah, so we're seeing some people who saw more than 4 F's there. So here's the paragraph here. So there's actually 6. It's always interesting presenting this in person.
Good. How are you?
Majak, we'll just get you to mute if. Oh, there we go. Perfect. It's always interesting presenting this in person because you can see the people who saw just 3 F's start to get a little concerned as more and more people put in their numbers. And although I didn't get a chance to, write a bit of statistics around the distribution, as your crowd gets bigger and bigger doing this exercise, they tend to migrate towards these numbers. So in large groups where you present this paragraph and you ask them to how many Fs they see, about half tend to see 3 Fs, about a quarter seem to see 4 Fs, and about a quarter see 4 or more Fs. And regardless of where I've presented this, these numbers tend to be pretty consistent. And so I'm going to suggest that in that context, there must be something shared that we all adopt in the course of learning how to read. And, things that we share across people and cultures and languages, etc., represent something that I'm going to call mental models. So the shared mental model in this case is threefold. The first is that we read for content. So although I gave you the task of counting the Fs, you were still trying to find meaning within the paragraph. So you were reading and you were trying to figure out, well, what does this paragraph actually mean? When you're rushed for time, you tend to skim paragraphs, especially when you're looking for meaning. And so you prioritize larger words because they communicate meaning. You're going to skip over those ofs that were inside the paragraph. And then finally, you're going to read aloud, especially if English is your first language. So the sound of F in scientific sounds very different than the F in of. So there are places where this mental model doesn't apply. So if English is not your first language and you think in French or you think in Cree or whatever the language is, this mental model tends not to work. And for whatever reason, if you never went through school past grade 4, you never had the chance to actually develop and solidify this mental model. So I'm going to go through one more exercise here and just have you read the triangles here. Once again, I'm going to give you 3 seconds. So I'm going to put this up here. Just read them left to right. I'm going to give you 1, give you 2, give you 3. And I'm going to ask you to read them one more time. And if you did not see what was inside the triangle, I want you to put in an N for no in the chat. There you go. Seems like there's quite a few no's. If you saw it, then you can put yes. Now, what's interesting about all of this is literally the same mental model. So there's actually no difference between this mental model and the one that you previously did. And for whatever reason, these mental models are often so strong that immediately after I explain to you how they work, they still work the same way that they did before. And this is the interesting part about mental models is that they're shared beliefs that arise from shared experience. People might have influenced us where we inherited their mental models, as well as a host of other reasons, the movies we see, the things we read day to day. All of these kind of contribute and are rooted within our personal identity. The mental models that you adopt become a part of how you define who you are. And as a result, these mental models then influence your conscious and unconscious behavior. And these mental models, they drive behavior in the absence of any intervention. So when you're just passively going about doing the things, your mental models actually take over and they help you to frame and filter the world around you. Now, mental models do not have to be true. They don't have to be logical. They don't have to be adaptive or realistic. But whoever has the mental models often think that they are true, that they are logical, that they are adaptive, and that they are realistic. And mental models tend to really cause problems when the usefulness of where they applied suddenly becomes maladaptive. At some point in somebody's life, the mental models that you read, the mental models we just used with reading, that's a useful way of actually reading through things and consuming content. But in this specific example, it ended up being maladaptive. Finally, with mental models, if you change them, you actually change behavior. And so unconscious bias, or the bias that often rests within these places where we talk about racism, sexism, classism, all the other isms, it's always rooted within a mental model. There's this quote that I really love out of Atomic Habits, James Clear. I don't know if you read the book, but it's really worthwhile if you're interested in learning a bit more about how habits work and about yourself. But he says, you do not rise to the level of your goals. You fall to the level of your systems, which I'm going to kind of relabel as mental models. So I'm going to share with you in a moment An example of some of the experiences that patients have related to the content of what we're talking about today. And I want you just to reflect on how you feel and how you think as you go through listening to this, and some of the mental models that might be coming out as you listen to these experiences.
Yes, I have experienced racism in our system with the doctor here and nurses. You know, nurses treat us differently. My file, every time I go there, like I'd be there before everybody, and I thought it's first come, first serve. But my thing would get, my file would get put to the bottom. You know, I'd have to wait there all day, and you know, I'd be trying to talk to one of the nurses, or talk to the doctor. You know, then they'd tell me, go sit down, like telling me to go sit down like a child. You know, I'm not a child, and then not wanting to speak to me, and then I see someone goes up right after me, like another patient, and they talk to one of them right away, and like they tell me they're busy, and that's with the doctor and nurses that they do that. Oh, for one thing, I'd like a different doctor. Plain and simple, a different doctor, and also better training for people skills for the nurses. They seem not to have any people skills, They get grouchy at us. The woman that sits at the desk that takes some names and, it sets us up. She gets grouchy with us. When I was there 2 weeks ago, I heard her swear and say effing natives. I heard that. I was sitting right there in that chair. She kind of whispered it, but I heard it. I heard it clear enough to make out effing natives.
Well, I know when my mother was in the hospital, she had diabetes and she had, like I said, heart, kidney, and lung problems, and she was in the hospital for about a month or maybe even 2 months. And when I went to visit her, she didn't have no sheets on her bed. They told me that she was on a mattress that didn't need sheets, but when they finally came to check on her, it was not that kind of mattress. And my mother wouldn't say anything. She wouldn't make any kind of fuss. She just laid on the rubber mattress, and that's it.
I'm a diabetic, and the one you're talking about, he likes touching women. He even done that to me too. And I used to wonder, is that possible for a doctor to do that? Eh? He slipped his 2 hands into my panties, but didn't touch my private. He done that from the back to the front. Eh? Boy, I was amazed when he just threw himself on the chair after he got that. And he was just blushing, just red. Eh? I just about swore at him, but then again, he might charge me. I should have swore at him at the time. I tell him the same thing what I experienced with him. Are they going to do anything about it? Like that. The time I broke my knee, and then when I was there for 5 days, and the nurse was coming to give me 4s, and then I told her, can I get a Tylenol extra strength instead of it? She got mad at me, and she went back to the where she keeps her pills to come and give me that Tylenol. And she holds my lips and then puts that pill into my mouth roughly. And I told the other nurse to put my leg on the pillow. She lifted my leg, put the pillow there, just dropped my leg. I was just being treated. If I was able to walk, I said I would have walked out of there. And I told my auntie, though, she gets the same treatment.
Well, a lot of old elders don't feel safe there. Like, I see elders when they're in a hospital, like when I go up there from my town, I talk with them. They don't feel safe. They look scared, but they don't want to say anything, but they look scared, and you can feel that on them, and that shouldn't be these are our elders, you know. They shouldn't be feeling scared like that. That's a place they should feel safe.
Kinds of things should happen. We should have proper diagnosis. We should have First Nation people at the doctor's office, the drugstore, throughout the system there. We should have a place for concerns to be heard, anonymity, and also online questionnaires or something to that effect where a person can actually just sign in and say this is what happened to them.
He's the only doctor we can see, so like what if we're really sick one time and he doesn't want to give us treatment because of that? And he will do that.
And that nurse there, that receptionist at the hospital, she used to be very friendly with me. Now I'm mad to her, I guess. For what, I don't know. You should see the way she treats them, very negative and looking angry. I just about told her the last time, why don't you quit your job if you don't like working for Indians? I just about said. I will do one of these days.
So you know that video, it's tough to watch, you know, and I imagine that for many of you, you have heard or experienced, you know, these types of stories in your day-to-day work, and it's tough to find a space to talk about these things in a way that doesn't reduce the persons who are involved into caricatures or two-dimensional characters in these stories where there's heroes and villains, and it depends on who's involved at the time. You know, patients are complaining, but they have these chronic medical conditions that they should be blamed for, whether it's, you know, addictions or non-compliance post-surgery, or, you know, these different terms that we throw around. Or, you know, you take someone who is a colleague who, you know, may be overworked, you know, may never have unpacked, you know, these things that they adopted and learned, you know, about people who look certain ways or do certain things or talk in certain ways, um, and are actually trying to provide good care, but, you know, are causing harm, and they're not necessarily um, equipped to work through, you know, these problems. They've never been given the space to actually go through and unpack these things. And I personally think that where we are right now as a profession is pretty profound. You know, we're saying these things out loud. You know, we're having conversations about stuff. And I hope that as we move forward, we realize that when we share these types of stories, like the last thing I want any of you to feel is that I think you're bad doctors, you know, or that if you've acted in a racialized way or in a way that could be interpreted as being racialized, that, you know, as a result, you're just inherently a bad person that's irredeemable, you know. And I think sometimes these discussions, they go to that place. And, you know, particularly practicing in rural Alberta, you know, we're 4 hours north of Edmonton, where people's last stop with major trauma and, you know, other types of surgical services. Um, we need people in these areas, and addressing racialization also has to balance people's access to care. And if we eliminated everyone who was ever offensive within healthcare, I don't think any of us would ever be working, you know. And so that's not to minimize or compartmentalize the very important harmful experiences that people go through as a result of racism, but it's to bring in just the practicality that we need to be able to get to that other side of what care could look like in a way that still lets us continue to build and increase the scope of systems. You know, I often use this table to discuss bias, discrimination, you know, the isms and racism in the context of colonization. You know, this is the ocean that we've all kind of been born into, that we swim around in. We talked about those mental models. They give us filters which then create bias, distortions in the way that we see the world around us, a lot of ways, in maladaptive ways. And when you project bias onto another person based on race, gender, age, socioeconomic status, etc., that's discrimination. Now, when we talk isms, that's when you discriminate in addition to taking away or being perceived to take away opportunity for real or intangible resources. So isms are when you narrow the amount of treatment options that you provide to somebody in your care. Isms are what happens when someone is delayed because of racism or sexism or other things to receive care in a timely manner. You know, um, and racism is one that's specific to race. And, all of this kind of floats in that historical context of colonialism, which was the historical and contemporary use of discrimination to actually remove rights to land and resources. Because at the end of all of this, these systems must have some sort of point. And the point of any of these isms is to make sure that there are people who have and people who have not, when it comes to resources and opportunities. There's many different reasons why mental models change. And I think when I look across physician groups, the environments that you work in, and the hard work of committees that work on issues like EDI and anti-racism, and I know there's lots of advocates that are kind of on the list of participants today. Each of these provide different opportunities and also different approaches to changing these mental models that kind of underlie that bias and that consequence cascade that we talked about. There's the opportunity for reflective learning. There's the opportunity for emotional awareness. There's the opportunity for culture shifts. And I'm going to talk about one specific mental model for system change, and this one combines a lot of these things together. So this is something called the Kubler-Ross change curve. It's something I came across in some of my business education. It's used pretty commonly when you talk about changing corporate culture. And if you look at the x-axis, that's kind of time, and if you look at the y-axis, opposition and motivation represent the emotional state of people within the system when it comes to supporting a change from the status quo. The Kubler-Ross change curve always starts with status quo. So status quo are a collection of those mental models that we've been talking about. And those mental models aggregate to create these norms of how we interact with each other. When you go to your clinic, you have certain expectations about how your room is going to be prepared, how you're going to be treated as a physician, your interactions with nursing staff. In some environments, there's a very formal interaction between nursing staff and physicians where, you're called doctor in all situations, and, there's not an overlap in scope or other things. There's other environments where things are much more informal. You might go by your first name. You may kind of have a mixed model for people doing different parts within the scope of care. But this status quo exists in all the environments that we work in, whether or not we know what it is or not. Now, when you move forward in the curve, it's usually due to some type of crisis that occurs or change that occurs. And that's usually rooted in that status quo no longer being adaptive to the situation that arises. And those crises give us an opportunity to think about the status quo not really working for people anymore. And we saw that frequently within COVID with each of the waves. I'm sure you all felt that at many times the status quo response to healthcare shortages, which in some cases is just work harder, work longer. That didn't work when you had a crisis that lasted for months before ebbing and then immediately started to spike again. If you can start to move forward towards some sort of status quo change, people tend to be motivated, but they eventually get to the point where they start to think about whether or not they actually want the change to occur. And they enter this phase of denial where they intuitively start to push back against changes in the status quo because it doesn't match up with these mental models that are in their head. It doesn't feel right that this change would happen. Things like meritocracy would fit into this. Even though we know that when people apply the people who are best equipped don't always get hired. We have these mental models of, whoever gets hired must be the best person for the job. They must be the one who has the most experience, etc. And there's lots of different reasons for this denial, lots of different mental models, and as many reasons as there are mental models. But this denial is like this intuitive pushback that stops the momentum of status quo change due to that crisis from moving forward. Now, if you have a big enough crisis or you have a well-organized enough group of people that are pushing for change, you can get through denial and start to enter into a different conversation where you start to talk about resistance within the system towards these changes. And this is where it dips the most within the Kubler-Ross change curve, because people do not like their lives changing. They do not like their livelihoods affected by these changes. And so while denial is this intuitive knee-jerk reaction or pushback against change, resistance is people thinking, well, I don't want to answer to someone different. I don't want to get paid less. I don't want, myself or my colleague to get fired or reassigned to a different department. These are the nuts and bolts of how we work day to day and the actual shifting of resources from one place to another. Now, if you get past resistance, you get into exploration and commitment, and then you eventually achieve, a new status quo, which then shifts the expectations within a system. And that can either go up or it could go down, but that delta between your original status quo and your secondary status quo is what we call cultural change. Now, we often focus on the first 4 steps, sometimes equally, sometimes not. I mean, we talk lots about status quo nowadays. Whenever a crisis occurs, especially very intense ones, we spend a lot of time talking about these crises, but we tend often to mix together denial and resistance and not really articulate how they're different or identify how they can specifically be addressed. And one of the things that I'll just underline, and I won't go into it in a whole lot of detail just because of time tonight. If you want to make a change in your system, the best places to focus are actually denial and resistance. Unpacking those mental models that people think are adaptive but aren't adaptive anymore. It's always interesting, like the mental model that patients should speak in English versus their primary language. Especially up north, and I'll use the example of Indigenous communities. People who go to Nunavut, where there's 85% speaking Nunavut, very few physicians actually know any phrases within a Nunavut, even though that is the language of the majority of people within many places in Nunavut. And it would actually be more adaptive to learn those phrases because you'd provide better care. You'd be able to get better histories. You'd be able to explain things in a more effective way. But we insist to have patients kind of learn how we speak versus learning how they speak. Resistance is also something that we can articulate. And I think it's a special place that physicians in particular can help with system change, because we understand why people don't want things to change. We know the reasons behind the reasons that we might not talk about openly. Shifting of expenses, shifting of income, changes in how long or short you work. Different groups that we then be accountable to. We have an in-depth knowledge of how this all works because of our unique place within the healthcare system. I'm going to leave you with a quote today before opening up for questions. And this is from Ted Cusance, who's a past chief over at Kisakus First Nations over by Yorkton. And he told me this years ago, but the quote he shared was, "Our stories are so out of the norm and removed from others' experiences that those others have a hard time believing that these things could actually happen. They believe these experiences are extremes. This is our status quo for those of us that live this reality. The status quo is no longer an option for us, our children, and our communities." I just want to say again that I know many of the names on the participant list here. I know the hard work that you do, especially in the context of, the whole system being on fire. And there are constantly crises that lead to us re-exploring whether or not we should change the way that we go about doing things, re-explore those mental models and the ways that we work day to day in order to make a better environment for ourselves, our colleagues, and our patients. And I have a lot of confidence in my colleagues across the country and in Saskatchewan. I truly believe that if we take the time to understand where people are coming from, and if we do our best to make sure that we're not reduced to those two-dimensional characters, those caricatures, those heroes or villains in these stories that we hear about racialization and some of our other challenges, I think we truly have a huge opportunity to make a change for ourselves and each other, and also the patients that we serve. So thank you, and I'll open up for questions now.
Thank you, Dr. Lafontaine. That was an excellent presentation, and I'm sure that it has given us all a lot of food for thought. And going forward, I think there's a lot of room for all of us to be more aware and more alert to the changes that we hope to see in healthcare. So we'll open it up for questions. If anyone has one, you can either raise your hand in the icon at the bottom or beside your name in the participants list, or you can type a question into the chat box. And while we're waiting, I have a question for you, and that is, how do we start making some of those moves towards improvement? And what are your thoughts about what each individual physician can do and what we can do as an organization?
And there's two pieces of advice from Murray Sinclair that I think are very applicable to the situation that we find ourselves in. The first one is that truth has to come before reconciliation. So we have to find a way to talk about these issues without modifying the content of the discussion to the point that it actually doesn't reflect lived reality anymore. I used to tour around with Verna Yu, who used to be, our CEO. She was over population health at the time over at AHS. And between the two of us, we used to call it the racism tour. We'd go to different parts of the province and, we'd talk about racism. But at the time that we were sharing, 10 years ago, we couldn't actually say the word racism out loud. It would actually just completely turn off the entire audience and we wouldn't have anyone to talk to. We don't have that problem today. But if we did have that problem, it would actually be impossible for us to unpack these issues with any sort of authenticity. So we have to find a way to talk about what really happens, and safe spaces, they have a lot of different components. One of them is being able to talk honestly about how things happen from our perception, and not interrogate the truth of kind of what goes on. Because one of the cycles that you often get caught in whenever people share stuff about, gender inequity or, racism or any of the other isms, or some of the very sensitive and risky topics that we have to talk about nowadays, is, this denial and pushback, right? Just like in the model where people say, well, that couldn't be true. That person would never do that. We kind of have to take the stories and just kind of let them sit, let the weight of it kind of move over us in order for us to actually start to unpack them. And the second part of that is something that Justice Sinclair says, which is reconciliation only works if you're in the room. And I think that acknowledges that not only do we have to speak truth to power, but we have to be able to still embrace each other and see each other as human beings in the course of talking truth to power. My own personal experience with racialization, and I mean, I was part of reporting a noose in the OR that was hung, that was directed against a Black surgical assist. Mm-hmm. Like the people who do these things or perform these actions, they're complex, nuanced individuals. On one hand, you could be saving a life, and then on another, you could be destroying it. And I think that's kind of this cycle that we get into, and in healthcare, we ourselves get dehumanized through, our working environments and our training, and we hurt each other, like in the course of going throughout our practice, and that's because we ourselves are hurt. And once again, I'll say again that doesn't take away the importance of doing things justly. Certain actions have certain responses that are required in order for us to have authentic responses. But I think it's important to separate the redeemability of the individual from the actions that they might do. Some of the greatest allies within fixing problems are those who cause them sometimes. And I think keeping that door open for people to know that there's the opportunity to work past those issues that maybe they weren't aware of, or maybe they were, and they created harm. That's something that will actually lead to better outcomes just in general for everyone. People do not like coming to hostile workplaces. They do not like feeling when they sit down with patients that they're going to have a bad experience. Patients don't like that either. And fixing issues with racialization and, the other problems that we have, it will create better working environments. Everyone will just be happier, coming to work. And I think stressing that for colleagues, that the end point of all of this is actually a better life for you too, is something that's really, really important in healthcare.
Thank you.
We have a question from Dr. Samra Salu. Go ahead, Dr. Salu.
Hi there. Thank you for giving me a moment to speak. I hope you can hear me. Can you hear me?
I can.
Okay, wonderful. So thank you so much for speaking to us today. I always enjoy listening to your talks, and I myself am from Treaty 4 territory, and you and your family used to come dance at my school, St. Augustine Community School. So shout out to you. Congratulations on everything. So I'm coming out of last week spent at the Samuel Uko inquest here in Regina. So this is a young Black man who was forcibly removed from our ER department, and then he drowned himself in the city lake. And I watched as his family very bravely stood up and asked their questions in the inquest, at which time the health authority lawyer that represents the health authority would object at every mention of diversity or anti-racism. And when the health authority was pushed, even in media, to speak to anti-racism, they wouldn't even say that word. They would say, we have diversity training in place. We have this already, but we don't. So what do we do when the public can see it? Even the jury commented on specific systemic anti-racism and interpersonal anti-racism training, but our own institutions won't answer to what the public can see, nor will it answer to what racialized and minority staff can see. So since there are a whole bunch of allies on this call, I'm wondering if you could speak to what do you see as the role of allies in addressing resistance from within institutions? In universities, we can appeal to, university declarations, we can appeal to Royal College, we can approve to wider national organizations and accreditation standards. But what do we do when it's our own health authority and when they're telling us that racism isn't a thing, despite the fact that we can all, I've lived it, I've lived here my whole life, I can tell you it's a thing. So I guess that's my question, addressing the resistance specifically from allies, because some of us are not in a position that where we necessarily get believed on what we're talking about, even as physicians. Thank you.
Mm-hmm. Yeah, thanks for sharing that. I did read about that experience, and it broke my heart that he went through that, and hearing about what goes on with the family and stuff, it does make me personally like really, really sad that they're going through this. I think in the context, and there's obviously many, many different layers to what's going on, and insights is, on one layer is understanding, things that don't make any sense to us. You would think that it would make more sense for the health region to embrace, these sorts of things. But one of the mental models that I've noticed at health regions is that, they'll minimize their risk as much as possible, even at the expense of patients, providers, frontline personnel. They would rather shut down or have people quit than, create opportunities for litigation, at least in their minds, right? And so that's a very maladaptive mental model that our institutions continue to carry on with. And I think you've seen shifts in some places in the country where, that zero risk approach, or at least that perception that they're creating a zero risk approach by denying and kind of shutting things down or trying to minimize as much as possible. People have moved to other things. We ran a project called Safe Space Networks in BC, And one of the things that we asked of the 10,000 participants who reported, experiences of racism into the app that we ran for 12 months, was asking the question, like, what do you actually want to get out of reporting this? Because one of the things that the health regions were very worried about is that the whole reason for submitting a concern was just litigation and, suing them and other things. And it wasn't surprising to those of us who lived this experience, but it was surprising to them. More than 70% of people who participated in the app actually didn't want to pursue any sort of litigation. They didn't even want, the person who caused the harm to get fired. They just wanted the harm to stop. And so part of what your challenge is in Saskatchewan and our challenge across the country is, how do we communicate to people that the things that they think are true aren't actually true? I imagine this family obviously wants justice in what happened, but I've always felt, and I believe in this situation too, they probably want justice tempered by mercy. They want nuance, but they want to stop the ongoing harm towards, persons who are racialized or dismissed because of the color of their skin or the way that they look or the way that they speak, and eliminate that future chance for someone else to actually go through that again. So, I mean, that's one of the things that can be done. Allies come in very handy when people don't want to open up and actually talk about what those root mental models are. One example is, you sit down and talk with a physician, no matter where you are in the country, you start trading stories after a while, and there's a warmth and an insight that comes when you have a shared experience. I've seen the same thing happen with administrators. I see the same thing happen with nurses. If you're an insider that understands or has relationships with those in decision-making positions, sharing in general, the thought processes of the people that are going through it and what they think they're working towards versus what they're actually working towards is something that's really, really valuable. I think the second thing that comes to mind is this whole idea that sometimes advocacy can migrate towards a scorched earth approach. And I'm all for burning down the forest, but you got to have something to plant after, And so you always have to mitigate the amount of revolution that happens with ensuring the sustainability of the system. Now, that always has to be balanced by, the weight of what happens. And, the death of a patient is a very, very weighty thing. I think persons involved in the situations probably have better context than I do. But that's a second thing to kind of consider. And then the third part is that the health region doesn't determine our conduct, right? Like, it guides our conduct, but to a great degree, we do have our own choices about what we do. We're still a self-regulated profession. Who knows if that'll last forever? But we have our own groups that we kind of work through. And so in the absence of having movement from the health region, we can stand behind people who do want to introduce this sort of curriculum. We can speak to our colleagues about the importance. We were having problems over at our hospital that were affecting the nurses in particular. Everyone within the OR all signed on to the same letter that then got sent off. Like, we were a unified voice for dealing with, these specific stressors that were weighing on our nursing colleagues. And I think that sends a powerful message, but it also shows that we can make voluntary choices to actually improve things without needing the rubber stamp of the places that we work. And I think that's one of the reasons why things like this are so important. The SMI's EDI committee, you have regional groups that kind of meet. I imagine you have a medical staff association at this hospital. You probably have EDI groups within that hospital, calling for change or just going ahead and implementing change within the context of what you can actually control can actually have a lot of power. And I've seen organizations get swept up in the momentum of change. Health region will resist until they can't anymore. Like, if everyone's walking past them and just going ahead and doing the right thing, hospitals at some point actually don't have a choice but to go ahead and do the right thing as well, or be left behind. And so, those are just some general ideas. This is a very challenging situation that you have right now. It mirrors a lot of the other challenging situations that people are trying to address with, Joyce Echaquan and, other patients that have met racialized harm. In my opinion, And so that's kind of the starting point, some advice, but then getting to that safe space where you can start to talk with each other and start to coordinate. That will happen if you start to, incrementally move towards unpacking, that denial and resistant parts of the graph.
Thank you so much.
My name is Dr. Carissa Brabant. I'm one of the family doctors in Moose Jaw, and I am Indigenous, and I have opened Circle Medical Center in Moose Jaw, which has a big medicine wheel on the logo. And I've wanted it to be like a beacon for Indigenous people to know that I'm here. And so far it's worked. I've got a lot of Indigenous patients who have told me that I have essentially changed their perspective of the system and that they feel safe in the system at least a little bit more than they did previously. When it comes to like next steps moving forward, I personally have found that being involved in teaching and in teaching residents and medical students has been a very strong way of instigating change. And while I don't necessarily have much of a question, it's more of just kind of a comment, is that when I'm teaching people and when I'm teaching residents and an Indigenous patient is in my ER or in my hospital or in my clinic, I make sure to tell my students and my residents that like this person might be here because they are very, very sick by the time they've made it to this point. And we need to keep that in mind when we are treating them, that if they're presenting to us and they have experienced some racism in this system, we need to be cognizant and respectful of that. It's my hope that moving forward every year, as these students and residents get further in their careers, it will be something that they carry forward into their careers, and this change will become easier over time. And I guess my question comes down to, is that something that you've seen over the years with all that you've been involved in over the last couple of decades?
Mm-hmm. Yeah. So congratulations on the work that you do. I'm really, my most favorite thing about interacting with colleagues across the country is actually hearing stories like yours, where people are doing
Thank you.
important work and, having positive impact. So just congratulations there, and congratulations for everybody who's on the call who is making a difference in patients' lives every day. You remind me of an experience that I had early on in my career up here in Grand Prairie, where there was a patient that came in. They were from, the far north, and they had been through multiple assessments to finally get to their surgery, right? So I'm seeing them in pre-assessment clinic, and I'm leafing through the chart, and it's fairly clear even before I talk to them, this patient is not appropriate for the institution that we're at. And I sit down and talk to the patient, and patients know like what's coming. They can sense it. And the patient started to get more and more upset. And then after I told them, it might be a better idea for us to transfer you down south to a larger center, they got very angry. Actually stood up from their chair and just started yelling and saying, this was a bunch of BS. And, I've gone through this for 2 years. And why are you the one to tell me no? And who are you? And who do you think you are? And all these things. And they were yelling so loud that the nurses came over from the room on the other side and, peeked their head in and just asked, like, do you want us to call security? And the guy's frustration actually reminded me of my uncle who had gone through a similar experience. And he was pretty sick at the time and kind of had the same thing told to him. And I kind of waved the nurses away and I let him yell for a bit. And about 10 minutes in, he actually broke down and started crying, and there's like this huge mountain of a man who's even bigger than me. And I'm like 6'3", I'm like 280, like I'm a big guy, and this guy's towering over me, and he's crying now in his chair. And he said to me, I'm just so frustrated. I thought I was doing everything I needed to. I've talked to person after person, and no one ever explained to me what was happening. And so I then spent the next, 15, 20 minutes explaining to him, like, down to minutiae, like my thought process. And I showed him his chart and I showed him the numbers and I said, this is what could happen and this is what will likely happen. And, shared with him like some of our ranking algorithms and, percentages and all these other things. And, at the end of it, he started to settle, and I knew he wasn't happy with the discussion we were happening, but he reached kind of a level of acceptance, and I would say almost bordered on being content that this was the right decision. And before he left, he actually said something to me that I'll always remember. He said, Doc, you were the very first person who ever let me yell at you. Every time I've ever gotten upset, I've been thrown out of the place where I've gone. And I think when I hear about what you're doing, and this is something that everybody can do like tomorrow, right? People have good reasons for being upset, right? We have good reasons for not wanting to get yelled at, like everywhere from personal safety to being on the 26th hour of, what was supposed to be a 24-hour shift, having to continue on with things, even though these catastrophes happen in between. We have good reasons for being upset, but we are the only ones sometimes who actually give space to people, let them breathe and actually feel that what they're going through like is reasonable. Listening to his story, it 100% was reasonable. I was actually surprised he didn't walk in and start yelling at me, the moment he like sat down. If I'd gone through what he went through, I don't know what I would have done. And so sharing that perspective with our colleagues and just reminding them, if you let people get through the anger, on the other side is actually understanding, and what we're often taught when it comes to stresses within the workplace, particularly when it comes from patients, is that, zero tolerance rule. Anyone raises their voice, anyone says anything that could be perceived as threatening, you're gone, you're out. And we do have to be careful because that is a real risk for us. So use your judgment. But if you're that person who lets people yell just a little bit longer than they ever have before, or you give them a little bit more space to create that tension, sometimes it leads to breakthrough. Sometimes they sit back and go, maybe people can listen to me. There's another quote that Ted told me in one of our projects. He said, we often assume that people have like this trauma that they contain within themselves that they want to withhold, when in reality they want to let the trauma out. It's just no one's ready to listen to them. People weren't ready for this guy to yell at them, but he wanted to. He needed to get it out. And in your day-to-day work, you have the opportunity to be that person who can take on that trauma, take care of yourself, make sure you have groups that you can talk with, work through these different feelings. Getting yelled at continuously is not something that's healthy for anybody. But you can create that space to actually completely transform the care that people receive. And that may be the very first time that they ever have a good experience in the healthcare system. And that can mean the world to them.
And I've found too that when patients are starting to open up and tell a story of where things have gone wrong in their healthcare journey, telling them, yes, you are correct. Something was missed. Like you were right. And telling them, like giving them that power back completely changes the game. Like it helps them become more engaged in their care if you admit that something went wrong, whether that was within your own institution or in a previous institution the patient has been in before. So that is something that can be done right away. Like you said, we can start doing that tomorrow. Don't need any special training on that. It's really just going back to the basics of what we were taught in medical school, is to listen to the patient in front of you. It makes a huge difference.
Yeah, thanks for that.
Christine, go ahead.
I have a question, and I know all of us are here want to provide better patient care, and at the end of it, I do think it is about the patients. But as a white woman who has witnessed staff members and colleagues being at the receiving end of racism, I would be very open to ways I can better support them. Because I think that's also, again, I think it's very important, the patient piece, but it's also not okay that my colleagues have had to be at the receiving end of that. And I don't always know the best way to deal with it. And I've found it interesting. I've received very little training on how to be an ally in that respect.
Mm-hmm. Yeah, so when we're talking specifically about racialization against healthcare providers, that intervention happens upstream. You know, like in the middle of it, and once again, this is differentiating between those spaces we can create for patients and when things actually start to get dangerous. That to me probably lands more in that dangerous part of the continuum than spaces to let patients kind of bring things out. And I'll be clear, in my own interaction, like, the guy never called me a racial slur. Or, he just said, "You doctors are all the same," and all those things. And I think when we look at influencing things upstream, it's having discussions with patient navigators on how they can impact things. Like, it's often having someone else within the system who's not in your position unpack these things with people. You know, um, it's very common for people who understand how the system works, and I mean this whether it's colleagues or whether it's patients, to leverage certain language, or leverage certain situations to try and get certain actions that they can then use to harm, you know. And so I've often found, moving that upstream, having people who aren't part of frontline care sit down and talk with patients about this and kind of unpack ends up having a positive effect. And just to reiterate, when you're caught in a situation where someone is using abusive language, truly abusive language, whether it's due to your gender or sexual identity or your race or other things, that is the place where these policies and stuff should come into place. And unwinding that is the role of the system, right? It needs to happen upstream from those situations. So how do you actually accomplish that? I think it comes down to figuring out how to make sure the risk stays um, within the institution, versus being moved onto the shoulders of the persons providing frontline care. And thinking through risk, you can think of risk as far as reputation, you can think of risk as far as litigation. It is a very serious thing to work in an unsafe situation in a hospital. Like, it's actually illegal for an employer not to address those things. And so there's often 3 reporting systems within the hospital. There's the one that deals with our regulators, there's the ones that deal with HR complaints, and then there's actual safety things. So in Alberta Health Services, we call it My Safety Net. If you write a letter to them saying that you feared for your own safety due to this or that, they are obligated under the health and safety acts that exist in every province to actually act on those things. So understanding where you report, how to phrase those things, etc., then creates obligations for the system to actually deal with your problem. So hopefully that gives you a little bit of a map to maybe start thinking through how these problems work.
Our next question is coming from Laura. But before I hand the floor over, I just want to note to everybody that the chat room is pretty active. There's lots of comments in there. And Samra actually put a link to some resources as well. So if you haven't been tracking the chat, have a go in there and have a look. And now we'll hand the floor over to Laura.
Thank you so much. And I really appreciate your incredible story. And it brings to mind the idea of racism in the context of a very colonized healthcare system. Colonized in the sense that there is very highly structured ways and control of the healthcare encounter that can come across as racist, or whereby the encounter is so controlled and manipulated by the healthcare industry that we don't allow for the story. We are restricted to the fixing. And you described an experience, not just between you and that patient, but you didn't go into fixing mode. You seem to have accompanied the patient, companioning more than fixing, and allowing for the emotionality to have a space, to hold space for the emotionality. And that's counterculture. And but so I wanted to applaud that story and embrace it, but also to highlight how can we decolonize the healthcare system as well, and how can physicians begin to realize and integrate that the health encounter has an emotionality, it has a spirituality, it has a story, and how we create time and allow for it and not be enslaved to the time and to the fix it model, and to trust outcomes, right? Measurable outcomes. So I'm wanting to know how you see that in a colonized system that's still attached to time and to outcome and to fix it, to fixing everything.
Mm-hmm.
So that's my question. And thank you so much.
Yeah, for sure. And thanks for sharing those things. And that obviously is a multi-layered question. The things that I think about from that question are, that we've all had to wall off parts of ourselves in order to survive the jobs that we're in. I still remember in residency the first time seeing a death in the OR, and like University of Saskatchewan, great place to train. But that night we had the death and then maybe a 10-minute break, and then we immediately launched into another case. And part of it was because the case had to get done. Like the patient was very sick. But I remember sitting there thinking about the situation and just thinking to myself, why are we going ahead? Why is there not some sort of redundancy to, take the weight off of all of us and give us time to grieve? Someone just passed. We were just part of a death. And I made the unconscious choice in that moment to start to dehumanize myself, strip away, the quote unquote emotional baggage that I had or linked to the care that I provided. And I started compartmentalizing, exactly what you were just talking about, the emotionality of, the human experience of being a doctor, the spirituality that goes along with it, us reflecting sometimes in the midst of chaos and patient harm, especially over the last few years, where we think to ourselves, why in the world are we doing this? Why are we doing it in this way? How could we have a system that enables these sorts of things? And it's going to be a painful process, and it's been a painful process for myself to kind of plug back in to the feeling part of who I was, and start to draw together those broken pieces that I purposely broke apart to survive in training. And to some degree, I think we all have gone through that. We've all dealt with it in kind of our own ways, but we've all been dehumanized to a degree because that is the requirement of functioning as a physician, especially in underserved, overwhelmed, um, ever rising expectations of these things. And you see it with primary care physicians who can sustain a practice but still provide care because we're worried what's going to happen to people if I disappear. And you're giving up your financial sustainability, you're affecting your relationships, you're harming yourself more or less in order to maintain care in a catchment that if you disappeared, they try and replace you on the next day and forget about your name. you know, Same for people in hospital who are going the same sorts of things. And so we do live in a system that's not only colonized, but also dehumanized us, and there was a point where that actually was functional because the rest of the system worked well enough that we could go home to the other part of our life and feel human again. Right. But it doesn't work anymore because the stresses and the crises are just too intense. And so how do we get back there? We're going to have to find our humanity again. I think conversations like this are a good starting point. We're saying stuff out loud that, back in training, even, 12 years ago, we would have never said, let's restore humanity and other things. People would just say, suck it up. This is what medicine is. This is what you signed up for. But having these conversations give you like small glimpses into what you could be on the other side. And I'll tell you from my own experience, like it is a lot of work, you know. I think sometimes as, presence of the CMA or other things, we project that we've got everything together or other things. But I mean, I've been broken just like you. I've sat down in ICUs doing things that I know I can do but shouldn't be doing, and thinking to myself, like, why is this the way that we practice? You know, feeling like I'm starting to lose faith in what's going on day to day. But the way we fix that is by leaning on each other. You know, and I think these conversations are not only good for our patients, but they're also good for ourselves. You know, and that's what I mean when I say, you know, on the other side, things can be so much better on the other side. Um, if we're willing to, you know, create those safe spaces, you know, have things be just, have things be authentic, but also not forget that we're all people at the end of the day, and we all have things in our heart and in our spirit and other things that we're trying to get out and heal. Sorry, I know I said that this was going to be heavy, but it's particularly heavy. So, yeah.
As heavy as it is, I think, you know, it's looking at that other side and wanting the desire for all of us to see that happen. And you start building a bridge by slowly bringing all the pieces together. And, you know, I think coming together this evening has been part of that. And maybe the movement will grow stronger and faster than we realize. So I thank you for those very wise words. Are there any more questions, Ivan, from the group?
I don't see any. Yeah, I think unless someone else has a question or a comment, we're probably finishing a little early. And
Hi.
oh,
I can't find the sorry, I can't find the raise hand. Oh, I found it. There I am.
there
I
it
can
is.
raise my hand.
I was going to say we could hear you anyway, Dale. Go ahead.
Thank you. Anyway, thank you so much for your presentation, Alika. Yes, I mean, I'm at the end of my teaching and clinical career. I, as once was an anesthetist, a GP anesthetist, and worked in up north in northern clinics, northern Manitoba, Nunavut, NWT, as well as practiced medicine in rural Saskatchewan for years. And we've often made the joke as rural physicians that we know a lot about everything, whereas those city guys know less, more and more about less and less. But I had the privilege when I was working for 2 years in Alika of actually having as a friend a medicine man who it was a reciprocal arrangement because I valued some of the things that he brought to the table, and he happened to be my patient because he was diabetic. So, and he had figured out that he couldn't fix it with his own, you know, he had his own traditional cure. And I came to think of it as when we're working in Western medicine, we're tending to work in that find it, fix it mode that leaves out those other things that patients need. And I don't know if how you may have the insights to know how we get to those things, because they are a like he said you had to know the whole patient, you know, and he compared it to atoms and molecules sort of in terms of the way we looked at medicine, Western medicine, and the way Indigenous people looked at medicine as a much more holistic thing. And so we're really tied to our kind of medicine, but we're so colonial it hurts. And I don't think we've been able to prove that we do something better. Do you see a way in which we all get together on this?
Yeah, I think it's a really great question, overlapping, traditional indigenous medicine with kind of Western ways of providing care. Um, I do think one of the big disservices of colonization has always been kind of a retconning of history, and as a result, losing, the nuance of what we built together. You know, um, when settlers first came to Canada, I mean, medicine really was bleeding patients out, and like the four humors, and you were coming to a place where there were poultices, people were harvesting medicines at the peak of their potency. They were being concentrated within teas, things were being mixed together. Um, half the pharmaceuticals that I use day to day in anesthesia are like come from naturally occurring substances that were not discovered by pharmaceutical companies. They were discovered by indigenous populations, which were then patented and, brought into current use, like everything from opium to curate to, you know, um, you know, birchwood. Like there's thing after thing. My dad has stories where he used to pick senecott um, with my grandfather in order to treat constipation. That was something that used to grow in Saskatchewan all over the place, and so I think learning that history helps to provide some bridge of that in the first place. Like things really aren't different, right? Like they actually all came from the same place. It's just we have this history that makes us believe that they only came from one place. And that might have worked back in the day. It definitely worked for pharmaceutical companies who wanted to sell, medicines without any patent violations. It worked really well for people who wanted to drive people towards kind of a Western system of providing care for good and bad reasons, but it's not working for us anymore, right? And I think we're definitely in a place where we're all sitting back and realizing things that we thought were right, things like isolating our kids in their room. I mean, there's lots of studies now that show that co-sleeping with your children actually leads to better attachment and, you know, better control of and regulation of emotions. And, there's all these little things that we kind of picked up, and we kind of sit there now and go, wow, I guess people were right. Like, yeah. And, acknowledging that and then diving into our shared history, I think is how we end up getting there. And there's a lot of fear, I think, and I can hear that from physician colleagues that, you give up your place if you cede your power, right? If you acknowledge that, there are answers outside of, what you have. And I think it's much more rare nowadays than it was for all of us, no matter the stage of your career, just because we've been having these conversations for so long. Um, but I think I just share some reassurance, and I hear it from you too, Dale, that, you know, if you cede your power, that actually leads to even more authenticity. That leads to patients wanting even more to get your advice, you know?
Yes.
Yeah. And so, yeah, just advice for people on the call tonight. If you're scared, don't necessarily dive in. I'm not a big fan of like going in both feet first, because you might have a really horrible experience and then decide that you'll never jump in that lake again. But
Well, I don't
yeah.
know that the very first patient
Mhm.
that my first mentor in medicine, this is first year medicine, University of Saskatchewan, probably about 20 years before you.
Yeah.
And the very first patient was a Dene man from up north. And the internist introduced him, I forget the name, but said, and this is my miracle man. He uses foxglove for his congestive heart failure, and I can't get the dose right.
Yeah, that's amazing. And sharing stories like that and opening people's minds up, we sometimes ask for people to share with us what's going on so we can interrogate stuff, when maybe the first step is giving people our stuff and letting them interrogate, whether or not what we're providing them is correct. And it's just inverting, the thing that, patients have never needed to prove to us whether or not what they do works. We can objectively sit back and say, your things have gotten better based on what you're doing, right? And if you create that space when things don't work, and there's a lot of things that don't work that patients do day to day, we can then have that authentic conversation where we can say with, some authority, um, you know, this isn't working. Would you try this instead? And once again, it just comes back to ceding power and all those things. But I think, Dale, you've had such a long career. I remember getting lectures from you when I was a medical student. I would love to hear a book that you wrote about your experiences and other things, you know, hearing
Thank
your
you.
history, I think would,
You'll be able
yeah,
to do that too.
yeah. So yeah, thanks for your comments.
Thanks a lot, Alika.
Yeah.
Any other questions? We still have a little bit of time, so don't hold back. Mark, your hand is up. Are you there? No? Okay, Madam Moderator, over to you.
I wish there were more questions. I'd love to hear you go on for a little while longer. I want to thank everyone for attending, and I am so grateful for your being with us and sharing your experience. Oh, Mark, you have appeared on my screen. Did you want to ask your question? I can't hear you, so you're on mute.
Okay, is that better now?
Oh, yes.
Okay, yeah, thanks very much for that, Alika. I just want to share something about maybe humor in a quite a serious situation. You know, by the time they come, people come for surgery, they've been through everything, and then they're on the operating table, and we do a pause and we talk about you know the patient's condition and any concerns and all that. And quite often it's you know, diabetes, poorly compliant, non-compliant diabetics. And once, you know, probably out of a need to sort of engage the patient for the last time before they go under and out of the hospital, I said to the surgeons, or said at the pause, that the patient is allergic to diabetic medication. And to which the lady said, "No, doctor, I'm not allergic to diabetic medication." And so, you know, for me, that helped to sort of break the ice and reduce some of the mystique around medicine. And I didn't think it was offensive. She took it in good stride. And I find that Aboriginal patients, they have a very good sense of humor, better than mine. And hopefully I wasn't out of line. Just wanted to share that with you. Thanks.
Yeah, thanks for sharing that. And I think one of the ways that, you know, Métis, First Nation, and Inuit people deal with stressful situations is by laughing, you know, making jokes. And, you know, I think if people feel your warmth when you're sharing things, like you can pick up on like the source of why you make jokes and other things. And I encourage you guys, like, just be authentic in your interactions, and you don't have to worry so much about saying exactly the right thing as long as you say it in a warm and authentic way. You know, it'll get picked up, and I know patients will definitely appreciate that. So thanks for sharing that, Mark.
Any more hands up? Last call. Seeing none, Dr. Lafontaine, thank you so much again for being with us. Thank you for sharing your time, your wisdom, your spirit with us. We greatly appreciate it. Thank you for all of the people who attended the meeting this evening. I think we have come away stronger and better because of it. And I am so looking forward to seeing you as my president of the Canadian Medical Association, our president as the Canadian Medical Association. We look forward to seeing you again, I hope, many more times.
Yeah, thanks so much for the invitation.
And with that, I think we'll say goodnight, everyone, and take care. Thank you, merci, and miigwech.
Thank you all. And thank you again, Alika. Appreciate it.
Okay. Thanks, everyone.
Take care.
feel free to reach out to the CMA. We try and make ourselves available.
Lots of applause.
Yeah, well, thanks for the invitation, Barb.
And if you can't hear.
Yeah, it was really great to chat and